Dear students, you are welcome to this lecture. Today we are going to look at endometriosis as one of our gynecological topics. I am Kiden Robina and I'm going to take you through this. Endometriosis is a chronic disorder where endometrial tissue is found outside uterine cavity. So we all know that endometrium is the innermost layer of the uterus, and what identifies it is the soft tissues that are contained that compose it. So these components, if they are found anywhere in the body, then it is what is referred to as endometriosis. So common age group that can be affected by this. This affects women between 30 to 40 years, especially those delaying childbirth. Someone between 30 and 40 and has never given birth has higher chances of developing endometriosis. Pathology: ectopic tissue undergoes cyclical changes leading to adhesion, formation, and possible chocolate cysts. Chocolate cysts, these are kind of tissues that will form in the ovaries of a woman. We shall get to understand it better as we continue. So common sites of endometriosis include the following: ovaries. In the ovaries, we can find the chocolate cyst, bilateral masses, often resulting in adhesion formation. So they will end up forming adhesions in the ovaries. Uterus, endometrial tissue invading the myometrium. This is what is known as internal endometriosis or adenomyosis, because we know that endometrium is the myometrium is the muscular layer of the uterus. So we do not expect to find tissues, or to find uh, components of endometrium in it. But this, if it so happens that the soft components of endometrium are again found in the myometrium, then this is what is referred to as internal endometriosis. Uterine tubes, common site unless amputated. So uterine tubes are also common sites for the endometrial tissues to be found. Rectovaginal septum had fixed masses causing dyspareunia. Dyspareunia is the pain that women feel when they during intercourse, during sexual intercourse, when they feel a lot of pain. That is what is called dyspareunia. So the rectovaginal septum can be affected by the endometrial tissues, and this can cause that painful sexual intercourse. Round ligaments, both intra and extra peritoneal portions. Then abdominal scars, common after hysterectomy or any pelvic surgeries. So it can happen in the abdominal scars, especially after hysterectomy has been done or in any pelvic surgeries. So what are the theories of pathogenesis? How does this come about? How do these endometrial tissues come to be found again in other parts of the body? So here some of the theories. One is the retrograde menstruation. So, most accepted theory suggests endometrial cells enter the peritoneal cavity during menstruation. This has been accepted that in like 90% of the women, endometriosis happens when the endometrial cells enter the peritoneal cavity during menstruation. Again, altered process. In normal menstruation, these cells are broken down and cleared. Endometriosis develops when this breakdown process is altered. So, in the normal menstruation period, these cells are broken down and immediately cleared off. But in case this process is altered in such a way that they are broken down but they are not cleared off immediately, then the woman may end up with endometriosis. Contributing factors to this include somatic mutations, mutation of the DNA, immune dysregulation, cellular adhesion, and proliferation. Inflammatory response. The endometrial cells outside the uterus react to estrogen, causing inflammation, scarring, and adhesions. Epidemiology of endometriosis. What is the prevalence? Endometriosis affects 10 to 15% of reproductive aged women. In women with chronic pelvic pain, prevalence rises to up to 70%. Prevalence in infertile women is between 20 to 50%. Clinical manifestations of endometriosis. Asymptomatic presentation. Some women with endometriosis may not show symptoms. Classic triad of symptoms: dysmenorrhea, pelvic pain before or during menstruation, then infertility, the person will not be able to conceive throughout, then dyspareunia, abdominal pain during sexual intercourse. We continue with the clinical manifestation, progressive and chronic symptoms. These include symptoms may persist for more than 6 months. Endometriosis should be suspected in women with infertility, especially if accompanied by pelvic pain. Women who have not been able to conceive even when they have unprotected intercourse for like the whole year and they are not able to conceive, then they are termed as infertile. So in most cases, this should be endometriosis should be suspected in them. Then intestinal obstruction symptoms. We continue. We look at the clinical features of endometriosis. So, the clinical features of endometriosis include the following: chocolate cysts, which can be bilateral or fixed masses. Then uterine enlargement, which is often indistinguishable from fibroids. It can be mistaken for fibroids. Then rectal vaginal lesions, which can be tender, fixed masses, and may simulate rectal carcinoma. Menorrhagia or irregular bleeding due to associated endometrial hyperplasia. Diagnosis and workup. Gold standard: pelvic laparoscopy can be done combined with biopsy for direct visualization and the diagnosis of endometriosis. Lesion characteristics. These vary in size. Color can be red, white, or clear, and may be vesicular in nature. So this is how it can be diagnosed. The gold standard is laparoscopy. A pelvic laparoscopy involves a small incision that can be made around the pelvic area, and a device is inserted to study the reproductive organ. Although those so once studied, then uh, we shall be able to identify the real tissues which are there. Additional diagnostic tools, MRI, can be used to visualize lesions. Then a transvaginal ultrasound. This one has high sensitivity and is specificity for ovarian endometrial mass. Nursing diagnosis for endometriosis, chronic pain due to pathological tissue changes, fatigue related to anemia, stress and ineffective coping due to infertility concerns. Management of endometriosis, history and symptoms. Focus on dysmenorrhea, menorrhagia, and dyspareunia. Physical exam should be conducted, and this may reveal tender, enlarged uterus or ovarian tenderness. Referral to gynecologist for advanced treatment is very important. Diagnostic tools, laparotomy may be needed to confirm diagnosis when cystic swelling is present. So let us look at pharmacological treatment that can be given to someone with endometriosis. We can give NSAIDs for pain relief. We can do combined hormonal contraceptives. This inhibit follicular development, reduce follicle stimulating hormone and luteinizing hormone, and it leads to endometrial atrophy. So once these two hormones have been reduced, then the endometrial tissue will not develop as rapidly as it has been. Then it will atrophy or it will reduce in size. And that means that they can solve the problem of endometriosis. Then progestins inhibit ovulation and they create a hypoestrogenic environment leading to endometrial atrophy. Surgical treatment, laparoscopic excision, recommended for superficial endometriosis and responsive to pharmacological treatment. So in case the woman has been put on pharmacological treatment and is not responding, then the person can now switch to surgical treatment, and one of them is laparoscopic excision. Then ovarian cystectomy for patients with ovarian endometriomas. If the endometrial tissue is found in the ovaries, then this can be conducted. Then hysterectomy with or without a bilateral salpingo oophorectomy for severe pelvic pain in patients who have completed childbearing. So for those women who have given birth to enough children, and we don't expect them to conceive or become pregnant soon, then we can remove the uterus, which is called the hysterectomy. So this can be removed together with the tubes and the ovaries, or can be removed and the ovaries left in place. Important notes: conservative therapy, hormonal therapy for young patients is very, very important. Surgical approach, hysterectomy for older patients due to decreased effectiveness of hormonal therapy. So in older patients, the surgical therapy may be more effective. Minor procedures, avoid near menstruation due to the risk of complications. So when the mother is nearing menstruation, then it should not be conducted. Management of endometriosis. Treatment options, like we have mentioned before, we have the surgical option, diathermy to destroy endometrial tissue can be done for patients less than 40 years. Then hormonal therapy, that is the progesterone, damazole can be given for 3 to 12 months. Pregnancy can suppress endometriosis naturally. So if the person is suffering from endometriosis and yet she is still within the reproductive age, then she should better conceive. For patients greater than 40 years, hysterectomy with the ovary removal. Education and follow-up to prevent recurrence of endometriosis. Patients need to continue therapy for several months despite potential adverse effects. So much as the patients are likely to go through lots of adverse effects, they are supposed to continue with the treatment for quite a long period of time. Teach patients about symptoms of interstitial and ureteral obstruction. Then follow-up assessments, cystostomy, colonoscopy, ultrasonography, MRI can be done to assess the response of the patient to the treatment that has been offered to her. So that marks the end of today's lecture. Thank you for following.